know me, my name is Lonnie Zwaigenbaum. I'm a developmental pediatrician and the site lead at the Edmonton Autism Treatment Network site, and work both clinically and in research. I'm really delighted to be presenting along with the co-principal investigator of this project, Dr. Barb Muskat, who's the Director of Social Work at the Hospital for Sick Children in Toronto, where there's also a Canadian ATN site, and Barb is also on faculty at the University of Toronto. Barb, with our co-principal investigator, Dr. David Nicholas, has really been a major driving force behind this qualitative research study, which is focused on the experiences of families and improving healthcare delivery in an emergency department setting. This study, in some respects, is an extension of previous research that Barb has led with David and I, looking at experience and care delivery involving children with ASD admitted to the pediatric ward. The emergency department represents an important interface between community health care and inpatient care, and so our current research is focused on improving care in the emergency setting. Next slide, please. So we'll just start with a case example based on a child who was seen in the Stollery Children's Hospital emergency room in Edmonton last spring. So this is a little girl who was brought by her father to the emergency department. This child was had a diagnosis of autism spectrum disorder, although the diagnosis was made at our children's rehab hospital, so it wasn't necessarily on the Stollery Children's Hospital chart. This little girl was having difficulties breathing as well as a high fever. What became confusing in her management was that she was really quite sedate and quiet, which from the dad's perspective was really quite unusual for this little girl who often presented with a lot of challenging behaviors, and yet from the perspective of the emergency room staff, she was essentially kind of a quiet and kind of relatively cooperative little girl. So whereas the dad was actually quite concerned about this behavior, the staff sort of saw her as a child not necessarily in such urgent need of attention. Her dad had to really emphasize her diagnosis and also her usual behavioral state to several medical staff who saw her while she was in the emergency department. And the dad sort of found himself sort of kind of having to strongly advocate and even sort of having to sort of argue at sometimes that against the initial impression that this child was really not that unwell. Next slide. So from the dad's perspective, from the healthcare, in terms of sort of the feedback from the healthcare providers in that situation, they recognized that she had been previously to the emergency room with croup. They recognized that they needed to take the repeat visit seriously, and yet they did feel that she presented sort of as kind of quiet and calm and therefore not in as much need of urgent attention. The dad, who was a police officer with quite a background as a medic, was really quite frustrated by the process. He felt like his role as a parent was mainly delegated to providing restraint as this little girl was having blood work done, and that his ability to recognize how her behavior reflected her health status wasn't really being respected. And in this case was actually really essential in terms of recognizing that her needs were actually more acute. He was also frustrated that he had to communicate the autism diagnosis repeatedly to healthcare providers who kept sort of coming involved in this little girl's care. And again, he felt like it wasn't just an issue of respecting and being aware of this basic piece of information, but in this case it was essential to interpreting her presentation and managing her health needs. And in general, the parent was somewhat frustrated that there just didn't seem to be a lot of good communication from the care team. And in particular, the physicians sort of briefly appeared and then disappeared, and the dad really felt that they should be a bigger part of the management of his child. Next slide. So the main objectives of this webinar are in the context of our AARP-funded study on family and healthcare provider experiences related to care delivery for children with ASD in the emergency department. We'd like to talk about potential risk and resiliency factors for children with ASD who are receiving acute health care. And we'll broaden the discussion not to just the emergency department, but thinking about other aspects of health care in acute settings. Next, we'll talk about strategies to improve acute health care for children with ASD and their families. And then finally, we'll share some of our experience of working with frontline staff and hospital decision makers to discuss and start to improve acute health care delivery for children and youth with ASD. Next slide. So despite anecdotes that some families of children with ASD are reluctant to bring their children into the emergency department, in fact, U.S.-based data from the National Survey of Health indicates that children with ASD do use health and mental health services as often or more often than neurotypical children, and in particular, more often use services in the emergency setting as well as in the ambulatory setting. And from a number of sources, children with ASD do experience unique challenges and potentially barriers to care. Next slide. So some of the potential difficulties for children based on informal discussion with parents and clinicians, as well as general descriptive information available in the literature. So first, the emergency department is, in some ways, has a lot of the characteristics that would be exactly the kind of setting that a family of a child with ASD might want to avoid. So there's a lot. It's a busy place. It's a bit unpredictable. And clearly there are a lot of intense sensory aspects to that environment in terms of the noise and the bright lights, and intrusive touch by unfamiliar people, and of course in the process of assessment and management, potential physical discomfort. And particularly in the context where a child is feeling unwell in an unfamiliar setting, these environmental demands may compound sort of underlying anxiety and sensory reactivity, and more likely to elicit sort of major behavioral symptoms, including meltdowns. Not only may the initial experience be challenging and somewhat negative, there's a potential, as we all know, if children, whether with ASD or other children more generally, who have negative experiences, it can certainly provide sort of lingering impacts in terms of fear and avoidance. Ultimately, the experience in the emergency department risks being somewhat traumatic over and above the health concerns, and the aftermath of that traumatic experience can certainly compound challenges with subsequent visits and other medical encounters. Next slide. Certainly, there are a number of challenges for parents as well, who rise to the occasion of becoming the child's advocate and translator and navigator, and yet they themselves are in a somewhat vulnerable state in terms of being concerned and uncertain about their child's health and the need for acute intervention, while at the same time having to manage and navigate their children's behavior, the challenge in the environment, and also in a constructive way work with medical staff that may not be aware of the diagnosis and or may have not had a lot of experience working with children with ASD. Certainly having a negative experience in the same way as it can be somewhat traumatic for children, it can be somewhat traumatic for families. And certainly families often face challenges within the health system, and some families of children with ASD, as you know, really face quite an odyssey even in terms of obtaining the initial diagnosis. And certainly there are a number of broader risks of having negative experience in the emergency department and in context with healthcare professionals. And it does compound the risk of really sort of undermining future partnerships with their healthcare providers, and perhaps even the likelihood of seeking care from traditional sources. The parents ultimately are looking for the best possible care for the children, feeling respected, and feeling that their children are being treated supportively and with dignity. As Susan Hyman has commented in her recent paper on medical home for children with ASD, really the lack of a medical home, and some children with ASD, as you know, have difficulty finding an appropriate primary care physician. By default, the emergency department may become an option, not necessarily the best option, but an option of dealing with health concerns. So families of children with autism may be particularly vulnerable to the unpredictability and potential challenges of the setting. Next slide. And then, of course, it's important to acknowledge that there are a number of difficulties for providers as well. Providers who may not have had the opportunity to have a lot of orientation to the diagnosis or the attendant challenges, who are dealing with incomplete information because the information about the diagnosis may not be highlighted clearly on the chart, may not be communicated between different healthcare delivery settings. And even where the information is available, providers are dealing with a lot of demands and having to juggle a number of responsibilities and ultimately kind of balancing the care needs of all their patients and trying to find the way of providing that extra support that would be helpful in allowing the experience in the emergency department to be more effective and more positive. So there are a number of potential challenges. I think one thing that we've been really impressed by sort of as we start to meet with families and providers is how motivated people are, regardless of whether they're coming from a provider or a family context, to improve care and to provide the child with the best possible care experience. And that really sets the stage for this study. So I'll turn the slides over to Barb now, and we'll talk about some data that really does set the stage for the current study.
Thank you, Lonnie. So I'm going to talk about two studies that exist kind of in parallel or have happened in tandem with the emergency room study. The first one was a chart review conducted by Dr. Justine Cohen-Silver, a pediatric resident in our emergency department, and Dr. Savikri Ratnapalan, who's a co-investigator on the ED study, where they looked at the demographic characteristics and presenting complaints of pediatric patients with ASD visiting the pediatric emergency department over a 12-month period. Next slide. Sorry, yeah. And what was interesting in the chart review was what was able to be unearthed was what was there when someone reported that a child had an autism spectrum disorder. So we were only able to get data when parents actually told the staff of the eMERGE, and it was listed in the chart that the child had ASD, which is something that I'll discuss at the end of the chart review findings. So what was found was that over a year period, there was 162 emergency room visits for 130 patients. That means that some of those patients were repeat visitors to the emergency room. As expected, there were more males than females, which is consistent with the population spread of individuals with ASD. The mean age that they came was 12 years, which is probably expected for a pediatric site. 79% of these patients had more than one chronic health diagnosis. Again, it fits the what we know about children with ASD. 44% of these patients visited the emergency department outside of daylight hours. 71% had a triage acuity score, which is 2 or 1, which was a high acuity health issue, which is what you'd expect for people bringing their children to the emergency department. And 33 patients were actually admitted. So the next slide, please. What's interesting is the 162 patients that came in were out of a total of 62,000 in our emergency department, which comes to a 1 in 383. What's interesting is, if we look at what the current estimate of prevalence of ASD in the population is, which is anywhere between 1 in 100, 1 in 88, depending on which stats you use, this is way fewer admissions than you might expect, given that children with autism spectrum disorders use health services as much, if not more, than other children. So what we suspect is an underreporting of the ASD. We don't know why, but certainly not all ASD diagnoses are written in charts. And part of that is we don't always ask, and I suspect that parents don't always tell. So we can only collect data on those people who actually told staff that their child has ASD. What we know is that 25% of those patients revisited the emergency department within days. That might tell us that either that there were higher healthcare needs in these patients, or it might indicate that the first emergency department visit didn't get at what was indicated with the child. And some of these questions, I think we're being able to find answers for through the emergency room study that's being funded by the ATN. And the next slide. So what were the specific presenting concerns of these kids? Some minor health complaints, mostly minor health complaints, but neurological issues, gastrointestinal issues, behavioral issues, and dental emergencies, which is what you'd pretty much expect from the population of kids with autism, which are associated with neurological issues, gastrointestinal issues, behavioral and dental emergencies. So I think our chart review pretty well represented the kids who come in. What it underrepresents is whether it includes everybody with autism spectrum disorders. Next slide. So the second study that is happening again in parallel or in tandem with the autism in the EMERGE study is Autism Comes to the Hospital, which includes many of the investigators. They're the same in both studies. So David Nicholas and Lonnie Zwaigenbaum and Wendy Roberts are involved in both. And what we were looking at were the lived experiences of children with autism spectrum disorders who were seen in the hospital. It was a two-site, similar to the emergency room study. It was done at two sites, the Hospital for Sick Children in Toronto and at the Stollery Hospital in Edmonton. And we conducted semi-structured interviews with children and adolescents with autism spectrum disorders, parents, and pediatric providers involved in their care. We did have 6 interviews with children, which was pretty amazing because it was very difficult to find children who were able to participate in an interview given communication issues, but we did end up with 6 children who participated. And I want to tell you a little bit about what we found in this study. So the next slide. So our findings span 4 general categories. That there were challenges, that there was flexibility that was offered by staff, there were approaches that were helpful, and there were other system changes that seemed to be necessary. And I'll talk to you a little bit about each of those separately. So next slide. So some of the challenges that were faced by the parents and the children during the hospitalization were communication, and this was regardless of verbal ability. That communication, particularly of what was happening for the child, was difficult. That parents often felt that they weren't necessarily being communicated with about their child's needs and condition, and that staff and parents were not adequately communicating about the impact of the autism and its impact in the hospitalization. There was certainly the challenge of the sensory distress from the environment and the medical procedures. As Lonnie discussed before, you know, all the poking, all the prodding, all the touching, all the noise. Certainly that was a feature during their hospitalizations. And something that we probably all recognize is waiting and changes. That kids with autism often have a hard time waiting patiently for procedures. There's often changes that happen in terms of timing of procedures, and these were very difficult for the children and families to cope with. A second piece was that parents were key in becoming the child's translator, that often they needed to really become like a case manager for their child. They had to advocate for the unique needs of their child. They really wanted to be listened to, and they wanted to be involved in their child's health care decisions. And indeed, when staff turned to parents to actually help them understand the needs of the child, the outcomes of the hospitalization were much more positive for everyone involved. Parents mentioned that when staff were open and sensitive and actually had a good dialogue with the families, and they approached their child with kindness and flexible ways of approaching procedures, parents had much more positive experiences. So some of the parents were involved in some medical services for some time, and those staff took time to get to know the kids and then knew how to adapt either the visit in the hospital or the visit to a clinic to take into account the child's needs. Even if it was like warming the stethoscope or knowing whether it was better to take the blood work without discussion or having a lot of discussion before taking the blood work, knowing the child and talking to the family was key to making that a positive experience. And what we heard from parents and providers was that staff really were going to value some training about autism, some renewed understanding of the variety of presentations of kids with autism, and ways that they could adapt their interventions for the needs of this population. Next slide. So some of the recommendations that we're working on right now, now that the study is finished, is we really don't do well here at asking families whether their child has any special needs. There are a lot of things that we ask coming into the hospital. We ask a lot of questions about allergies and medication and sometimes medical coverage, but we don't necessarily overtly ask families whether their child has special needs. And if we do ask, we don't always ask what works for this child and what can we do in advanced preparation to make this visit a better one. So one of the recommendations is to involve families from pre-admission to admission to during the stay and on the way out. A second recommendation is that, which is not surprising, is pre-planning and prevention work better than intervention in the midst of a crisis and meltdown. We did a focus group with our child life staff here at the kids. They're often the people called in to help kids prepare for procedures, to help set up a stage for a successful procedure to happen. And what they felt was, in the cases where they were called in, they had all kinds of things that they could use to adapt, to make things better, to make things easier. And when they were called in ahead of time, things went smoothly. But unfortunately, what often happens is if nobody tells and people don't know, you only actually find out that the child has special needs in the middle of a crisis and meltdown. And what I think we all know is it's much harder to set a situation right in the middle of a crisis and meltdown. So pre-planning and prevention are key. We don't always tell parents to make sure to bring along their child's favorite object, to bring things that comfort them, to find out what's going to work to make this child as comfortable as possible. And we need to also involve the child in helping us know what's going to help them regulate during their stay. Something that's harder to do, but certainly not impossible, is to help staff manage the sensory environment, headphones, quieter areas, turning down the volume on the overhead, whatever we can do to help manage the sensory environment. And finally, when staff can engage with the child to get to know them well, if they have special interests, to talk to them about their special interests, to use a gentle approach, a nice tone of voice, respect their personal space, adjust their communication level to the child's needs, all kinds of interventions which are just good practice for working with children with special needs. And I think for my final slide, which is next, is we're working on a number of next steps, and we'll talk about these more after Lonnie talks about the EMERGE study, but we are working on knowledge translation plans. We're developing a tool, we'll discuss it at the end, that parents can use. We're consulting with our local ATN parent network and our hospital family council to further develop the tools. We're hoping to pilot some of these tools and do some dissemination on parent-oriented sites. And those are things that we'll be discussing at the end of the presentation. So I'll turn it back to Lonnie at this point. Thanks.
Okay, great. Thanks, Barb. So now we'll move on to discuss the current AARP-funded study. And on this slide, we list the investigators who are involved. There are some real parallels across the two sites in terms of the membership of our teams. We have David and Barbara who are bringing the social work and qualitative methodology to the teams. Wendy Roberts and I sort of provide a developmental pediatrics perspective. At each site, we have people who are working directly in the emergency room setting. William Craig in Edmonton and Savitri Ratnapalan in Toronto, who are both emergency physicians, both who have strong interest in supporting children with disabilities and other exceptionalities. Amanda Newton in Edmonton is actually a nurse researcher whose focus is health service, particularly mental health care delivery in the emergency room setting. And then Rafi Sharon in Edmonton is a community pediatrician who brings that perspective. And Barb introduced Justine Cohen-Silver earlier. Really want to acknowledge and thank Matt Millen in Edmonton and Andrea Greenblatt who are in Toronto, who are our coordinators. And I will point out that perhaps one important gap in our research team is to actually have parental involvement directly on the research team. Although the parent advisors of our Autism Treatment Network sites have certainly been integral to the project in terms of providing a sounding board and also starting to play more of a liaison role and thinking about how to implement some of the ideas that are coming out of this research. Next slide. So the main questions for this study are, what are the emergency department experiences of children and adolescents with ASD as well as their families? What challenges do healthcare providers face when providing care to this population in the ED setting? And then perhaps most importantly, what resources and supports are perceived to be needed to optimize care in the emergency department for children and youth with ASD as well as their families? Next slide. So this is a qualitative study using a grounded theory approach. Really the lens is, how do children, parents, and care providers experience emergency department care delivery? How do they think about what constitutes optimal care in terms of what are their priorities, expectations, and needs? And ultimately, what are the key insights with respect to practice and system change? As I'll mention on the next slide, there are essentially two phases. The first, qualitative interviews focused on particular visits to the emergency department, and then the second phase is in-depth interviews and focus groups with key stakeholders, trying to really derive insights from those individual care experiences to think about practice and policy change. Next slide. Sorry, I've just lost from my computer screen. There we go. So as Barb alluded to, this research, like the Autism Comes to the Hospital research, takes place at two settings, which happen to be the two Canadian sites of the Autism Treatment Network. Again, there's some interesting parallels across the sites in that the care of children and youth with ASD is off-site of the Children's Hospital at Children's Rehabilitation Centers. And each site has a specialized pediatric emergency department, which serves a bit of a hybrid role of being a tertiary center with kids coming in from other communities, but also serves as a community pediatric emergency room. So children living in the particular neighborhood or within the city will often choose to bring in their child, even if the nature of the health concern isn't necessarily tertiary in nature. And then, as I mentioned, there are these two phases of the study, which I'll talk about in more detail. We're at the point where we're completing the interviews for the first phase and really transitioning into the next phase of bringing people together around the table to develop consensus recommendations for practice and policy. Next slide. Our recruitment strategy has really been to work very closely with the emergency department staff, particularly with the support of the members of our team that are embedded in those settings. When the families are in with their children and at ASD diagnosis is identified, the emergency department staff asks the families for permission to release their contact information so that they can be called by the study coordinator at each site. In addition to having the investigators working right within the emergency room, we've spent a lot of time. We've had pizza, we've had coffee, and really providing in-services to provide an orientation to the needs of kids with ASD, to provide initial forum for staff to talk about the issues that they identify, and really then to engage them in participating in the study in identifying potential families to participate. We have a target sample, but ultimately we continue to recruit families and healthcare providers into the study until we achieve what's viewed as saturation in qualitative research, or essentially that we start to hear the same story and the same theme repeatedly, and we begin to get the sense that we've covered our bases in terms of hearing the diversity of perspective and the range of situations that can arise. Our current participants include 21 families, and from those 21 families, we have a parent in each of those families. We have healthcare providers in most, but not all of those families. In each case, the parent sort of identifies a healthcare provider who was integral to the child's care in the emergency department. In some cases, we haven't been able to track down the healthcare provider or gain their agreement to participate by interviewing, but we've been encouraged that in most cases the healthcare provider has been willing. We have had more of a challenge, even compared to the study of children in the pediatric ward, in interviewing youth, in part because despite the Toronto data, the Toronto sort of census data on children with ASD being seen in the emergency, our participants actually have tended to skew somewhat younger, and in many cases have been nonverbal. And part of our strategy of ongoing recruitment is to focus in on that segment of the group of kids with ASD who can sort of speak directly to the issues. So focusing in, looking for somewhat older children and children who are able to participate in the verbal aspects of the interview process. Next slide. So what I'd like to do today is start to present some of the preliminary results coming out of analyses of the initial set of interviews that have been completed. And these are formed around 3 or 4 general themes. The first is general challenges associated with the emergency department visits. And in a sense, these are not surprising, sort of given Barb's comments on what families had to say about their care on the pediatric ward, and also sort of what we've known informally in talking to families. But certainly these experiences come very vividly to life when focused on sort of particular encounters. So certainly the wait times are a struggle, and although not specific, of course, to kids with ASD, do present sort of particular challenges. Certainly communication is a common theme, and as Barbara said, it's not simply an issue of verbal versus nonverbal communication or not being able to communicate with children that lack language skills, but rather communication between the emergency department staff and the parent, making an effort to sort of translate in a meaningful way so that the children understand what's happening and anticipate the various steps of procedures. And then certainly the environmental issues do come up frequently. I do want to say, though, that the flip side is that these interviews have not simply been about the stress of the emergency department visit. There's actually been a number of encouraging stories where parents have really highlighted the positive aspects of the experience and really the efforts of the frontline staff to take into account the needs of their children and to adapt their approach accordingly. Next slide. So Barb touched on this issue, which perhaps drives the lower rate of autism among the population of children being seen at the Sick Kids Emergency Room in Toronto, and that is the struggle of whether to disclose the child's ASD diagnosis or not. And clearly, we're only tapping into those group of families that eventually come out on the side of the decision that they do disclose the diagnosis. Certainly there are probably a number of families that elect not to disclose, and we need to sort of tap into that group through some other mechanism, perhaps by approaching local advocacy groups like the local autism societies and talk to parents about, who've been through the emergency room but have actually sort of managed where in the end the diagnosis does not come to the surface and ultimately wasn't part of the discussion. A number of parents have really talked about sort of what they ultimately grapple with in making the decision about whether to share the diagnosis or not. And that is, will it serve the situation and will it help the emergency staff with managing their child if they communicate the diagnosis? And ultimately, what's the primary driver? Is it ASD or the presenting medical issue? And parents often find themselves in a bind. They recognize that knowing that the child has ASD may provide some direction in terms of strategies to modify the environment, to communicate in a different way, and to really cater the experience to the needs of the child. And yet they also have some concern and some apprehension that disclosing the diagnosis will lead the emergency staff to sort of focus in on sort of whatever their preconceived notion of children with autism is, and not focus on the child as an individual, and maybe even become distracted from the acute healthcare issues and attribute too much to the ASD diagnosis. Next slide. Next is the importance of providers' ability to engage with children and youth, and this really sort of builds on this whole issue around communication. It's interesting that many families we've spoken to have had negative past experiences with professionals, that is clinicians or educators and so on, who seem to only see their child's disability or sort of think of the child as a diagnosis first, rather than getting to know the child as an individual. So this really did influence and make it a very difficult decision around disclosure. Certainly knowing the child's strengths, challenges, preferences, and aversions was essential, as was the need to communicate what was happening. And as Barb commented, the parent often found themselves trying to act as a translator, trying to help the child make sense of what was going on around them, translate what was being said in using language more appropriate for the child's language level, or demonstrating what was happening in different steps. But as the little girl, as in the little girl who we presented in the initial case scenario at the beginning of the webinar, it's important to establish a baseline outside of the situation. For that little girl, recognizing that her baseline was actually a number of challenging behaviors, and that actually the absence of those challenging behaviors was an important indicator of the significance of her health concerns. Next slide. Both parents and care providers highlighted the need for ongoing education and practical resources to support their patients, and in particular children with ASD in the emergency department. A number of clinicians that we spoke to acknowledged that they simply received little training in medical school and nursing, in other areas of healthcare professional development around ASD. And as I commented, it was clear in speaking to the healthcare providers that it was almost universal that the providers recognized the importance that the healthcare experience be tailored to the needs of the child in order to be more effective. Not simply that it was a positive experience, but even just that it was more effective in more quickly addressing, more quickly assessing the needs of the child, intervening, and doing it in a way that could be integrated into the busy environment. But there was a recognition that more information and supports were needed. And again, almost universally, the frontline staff really welcomed that opportunity. There wasn't a sense of defensiveness, but recognizing that we were tapping into an issue that they had already been thinking about. So next slide. And then, as I commented, we're now transitioning into our second phase, which will involve interviews and focus groups of various stakeholders, including parents and clinicians, but also bringing to the table some of the key health decision makers at both the emergency department and hospital level. And really sort of bringing, sort of trying to distill the findings from the interviews to present different scenarios, help the various stakeholder groups understand the perspective through the perspective of the healthcare providers, but also the families, in order to develop some consensus recommendations, and then really start to develop some practical strategies for moving forward and improving the care. Next slide. And actually, I'll now move this back to Barb in terms of talking in more detail about our strategy in terms of, once we have these discussions, once we share these experiences with healthcare decision makers, what kind of practical strategies could come out of that discussion. And then we'll turn it back to me for a couple of slides, and then we'll move to discussion. So Barb, please go ahead.
Okay, thanks, Lonnie. So we've been thinking a lot because of the first study and this study together in terms of what we need in a knowledge translation plan. And some of these items are, as we've said a few times, some continuing education and training opportunities and partnerships and development of toolkits, information booklets and materials for 3 audiences, for the children, for the parents, and for staff at hospitals, and working with hospital leadership to implement new practices. So these are the broad scopes, and I'll tell you where we are since we're doing a few things, as I keep saying, in tandem, but we're already kind of on the track for starting to develop some of these plans. So next slide, please. So what's been interesting is on the Autism Comes to the Hospital study, we brought the findings from our study back to a focus group of participants in the study, some young adults with autism who had been patients in pediatric settings, and staff at the hospital. And we discussed various tools that we were thinking of developing, as well as sharing the findings from our study. And something that has come up as very important for all the different constituency groups is to help parents be as prepared as possible to come into the hospital in a ready position to translate for their child. And what we were told is we should be working on something kind of a "this is my child" document, which needs to be on one side of the page because that's all you have time to present, and to be able to say, this is what you need to know about my child, and this is what works. So we are in development. That's in development, and I'll be talking about where we're taking this to get feedback from other stakeholder groups. But in short, we're taking it to parents, parent councils, ATN, parent council, to various constituency groups here at the hospital and then in Edmonton, because this will only work if it works for the people who are going to use it. So that's currently in development, something that parents would have as a tool to bring with them. A second potential toolkit would be creation of a toolkit that can help children understand what's going to happen in the hospital. This is something that some hospitals are already using. Actually, Our Child Life is already doing this in some ways, that using technology, you can create social stories for kids to show them the places that they're going to be in the hospital, pictures of the actual locations. I believe here at Sick Kids we have pictures of the actual blood work room rather than a cartoon about it. So there's some thinking of creation of these social stories to help children understand what's going to happen and prepare them. There's been interesting discussion here at the hospital about what kind of mechanism we could develop to ensure that the information about the child is communicated among the hospital staff, so the parents don't have to continuously retell their child's story and to say to every staff they meet, you should know that my child has autism. That's one of the biggest frustrations that we've heard, and that's a piece of the story that often doesn't get communicated when kids move, like in the emergency room, seen by different health staff. If they come into the hospital, how that communication keeps being communicated. You know, do you stamp it on a chart? Do you put a little puzzle piece on their lapel? I don't know. We have to figure out what we can do to ensure that parents don't have to repeatedly tell this information, and that staff understand the implications of what it means. And then we've been saying over and over, development of staff education to help staff understand neurodevelopmental differences in children and their implications for medical treatment. I think many of our staff take some kind of course or have some kind of education early in their training, but after a while, they may not remember what they learned, and they tend to kind of reach for it when they have a child with a neurodevelopmental difference in front of them. So we feel there's probably something that we can develop to keep that training live. Next slide. The way sometimes things work, serendipitously, we found out that our colleagues at the Children's Hospital of Philadelphia have done a somewhat similar project in their sedation unit, where they were looking at the experiences of kids with autism in the sedation unit. And consequently, we're collaborating with them around some of these, some of the tool development. They developed a tool for universal screening at the hospital where they had staff ask common questions, and our tools are more empowering parents to bring something in. But perhaps we need to do a multi-pronged approach where parents bring something in, people ask parents, and kids are prepared as well. And I think what we'll know more what approaches to take as we go to our stakeholders of parents, kids, staff, and other community stakeholders. Here at Sick Kids, we've been very fortunate to have these focus groups with stakeholders from our study. And as well, suddenly there was interest here, and we were able to present some of the findings to senior directors here at Sick Kids. So to our CEO, to our chiefs of pediatrics and nursing, to our interprofessional practice group, and our senior quality management team. So we've been very fortunate to start getting the word out on the findings of all of these studies, and they'll be very interested to hear what we find from the ED study. And what's been very interesting is there's a real desire to do better by the kids with autism spectrum disorders. And what was interesting is they said it's going to be easier to empower the parents than to change practice across the spectrum of staff at the hospital. So they liked our parent empowerment tool. So I'll leave it at that and turn it back to Lonnie in terms of other partnerships and outreach activities.
Great. So just briefly, I think for both of our sites, being part of the Autism Treatment Network has really helped open up some conversations and allowed the autism teams to be working more closely with the pediatric care providers. And at the same time as we've been working on this study, our autism clinic team, led by Barb Trail, who's both our clinic coordinator as well as our ATN site coordinator, she's worked with her interdisciplinary team to provide clinical in-services to a number of outpatient clinics, and really following a similar process as the research. Her team did some prep work in terms of talking to families, identifying what was working well and what the challenges were, and then began meeting with frontline staff to help them understand some of the challenges, to give positive feedback, of course, where appropriate, and really develop some really creative ways of helping the staff understand what the kids with ASD were going through, and then problem solve to help deal with some of those challenges. For example, her team met with the clinic staff in the sleep lab, had a couple of the staff blindfolded just to sort of try to represent a situation where someone didn't know what was coming and sort of wasn't sure what was, what to expect, and then hooked them up to a sleep monitor and prepared them for a sleep study. And of course, they, even knowing what was coming from past experience, found the whole experience somewhat aversive in terms of having wires up their sleeves and so on. And it really was a bit of an aha moment for them of how to approach the situation with the patients. So, some of the insights from that, next slide, are that although we we risk sort of having a bit of a default position where we think that that practice change is always going to be top-down. In fact, sort of having frontline staff work directly with frontline staff has actually been a very effective way of implementing creative practice change, such as the questionnaire that Barb was referring to. And really engaging the people who are going to be working directly with the families and sort of bringing them on side can go a long way in terms of changing both the culture and the practice. And along the way, really what our clinical team has discovered is that often these different settings, despite sometimes mixed experience among the families, often settings have their own local champion who really understands autism and is the one sort of quietly going about providing exemplary care, supporting their colleagues and advocating for improvements, and really identifying that person and bringing them on side and working in partnership rather than in a way that's unidirectional. It can be a very effective strategy of implementing new approaches. Certainly, as Barb alluded to, providing practical resources and how-to, and really building on the model that ATN has implemented so well in terms of toolkits and other resources. And then, of course, providing some, in the autism field we would call positive behavior support, and not being stingy with praise and really reinforcing the efforts of these staff, who are really very invested in improving the care of kids with ASD. So to briefly summarize, there's no question on the last slide that children with ASD do have unique vulnerabilities that can add to the stress of acute care management, and we've talked about a number of these in detail. We really feel that a multi-pronged approach of engaging both the higher-level decision makers but also the frontline healthcare providers can be very effective in implementing practice change, and we've been very encouraged that these new ideas and resources have been well received. And our study continues to progress in terms of completing interviews and holding focus groups to further discuss practice and policy, and we hope to have the opportunity to update you at a later date. So thanks everyone for sitting in on the webinar, and we're glad to open this up for discussion. We'll just move to the final slide of acknowledgements and just briefly acknowledge the other members of the research team, our wonderful staff and funders, and of course the absolutely terrific children, family, and healthcare providers who participated.
So if anyone has any questions, we have time for a question or two. If you could raise your hand or type in a question, that would be really excellent. Let me just look here for any hands raised.
I think I see Jim. Oh, maybe not.
Yes. Jim, would you like to say something?
Sure. This is wonderful to hear this, Lonnie and Barbara and colleagues. I'm sort of curious what you think you learned new as a result of this work. It's obviously, among other things, done a great job of opening up opportunities for conversations with people. That's been a tremendous step forward. But are there insights into the emergency room experience that you've developed that result from the study? So the study is ongoing, but I would say even based on the preliminary look at the data, one finding which wasn't entirely anticipated was just sort of how much of a dilemma the issue of disclosure is, and how parents don't necessarily aren't necessarily sort of eager to disclose the diagnosis, and it can actually be a very painful consideration. And it really does, I think, dovetail with Barb's finding that the number of children identified from a simple chart review seems to underrepresent kids with ASD. I think this really compounds sort of the poor communication across different health contexts and the fact that the child's diagnosis is not necessarily going to be easy to find on the chart. So we have a situation where we have some reasonable practical strategies to improve care and a healthcare staff that is motivated to improve care, and yet we can't assume that the diagnosis is going to be automatically communicated and on the surface. So it's actually a piece that we really hadn't anticipated, but clearly that needs some further attention. Barb, anything that you'd add to that? Any sort of, particularly with the wonderful work in the Autism Comes to Hospital study, any additional kind of insights or lessons that seem to be coming out of the ED study?
I guess the only other thing that that we heard from staff is the kind of moral dilemma about triage, like whose needs are greater. a child who's having a meltdown who has to wait, or, you know, triage in a more traditional medical fashion, and that they're really thinking about what they can do about this triage and emerge. Like, is there some other better way to deal with the waiting and help kids with the waiting who aren't triaged? I think it's kind of become a moral, ethical question, which is interesting, and I imagine we'll hear more about that.
Great. Thanks, Jen. It's an excellent question, and we'll continue to think about sort of how this study complements sort of insights that are available from, you know, from previous research and from speaking to the families we work with.
So we have a couple comments that were typed in, and I just wanted to go over them very briefly. But there are a few what looks like tools. For example, MGH has an autism treatment plan that families complete before they arrive for treatment. Yona Lunsky at CAMH, she is doing something for persons with developmental disabilities in ER visits. And there's also Alicia Curran at Missouri is working on a toolkit. So perhaps there could be some collaboration along those lines.
Yeah, it's a great idea. The Toronto team has actually already been in touch with Yuma, who's at the CAMH, as you mentioned. And I agree that as we move to the point of developing more toolkits and resources following the second phase of the study, I think we really need to coordinate our efforts across the ATN. And this might be a good time to be thinking about a specific work group that focuses on this issue, so that it's not attached to a single center or a single project.
Excellent. So I don't see any other hands raised. Anyone has any questions? Well, I want to thank everyone for attending today's webinar, and I appreciate all of your feedback. Lonnie or Barb, do you have any final comments for us today?
Maybe I'll just comment. I mean, we really do appreciate the opportunity to come back to this group and talk about progress with the study and sort of in general sort of where the field is going. And in particular, it's really helpful hearing about efforts to develop toolkits and other resources at other sites. And I really do like the idea of forming a work group and more formally having some discussion about how we can really sort of pool our efforts, kind of draw from lessons from various sites and come up with something that could be applied network-wide and beyond. Barb, any other sort of closing comments?
No, I think you did that very well, Lonnie. Thank you for allowing me to be part of this. It's been it's wonderful to share what we've done and to hear comments from other folks.
Wonderful. Well, thank you all for attending today, and the recording will be sent around shortly. Thanks again. Bye-bye.
Great. Thank you, Alex. Take care. Happy holidays, everyone.